Hi, I'm Kevin Kalinsky. I'm a breast oncologist at Columbia in New York City. I'm an associate professor of medicine at Columbia. And thank you for spending the hour with me talking about optimizing therapy in HER2-positive breast cancer. I'm going to go through these slides. You are welcome to ask questions. And I'm also just going to give you my email now in case questions come up at kk2693@cumc.columbia.edu. And I just want to say that these slides were developed by one of my colleagues, Reshma Matani, who's at University of Florida, who did an excellent job putting these together. So, what we know is that treating HER2-positive breast cancer has really changed in both the operable and the metastatic setting. But in terms of the early stage setting, we've seen significant outcome improvement, with trastuzumab and then also with other agents such as pertuzumab and TDM1. But questions that have come up is, do we always need to give or ever need to give an anthracycline? What about a full year of trastuzumab? Can we de-escalate chemotherapy? And when is more better? And what about the utilization of other agents such as neratinib, pertuzumab, and TDM1? So in terms of what remains an unmet need, we still need options to improve outcomes in patients with CNS metastasis. This is really the unmet need in HER2-positive disease. But even with targeted drugs, we're still seeing resistance occurring. And on the other hand, we've seen in the last year approval of Catnip as well as trastuzumab deruxtecan, and we'll talk through some of those data. And we'll also talk about the data which have led to the approval of neratinib in patients with metastatic disease. It's also approved in the operable setting. And we'll talk about some future directions. So what we know is that HER2 used to be associated with a more aggressive disease. It's a poor prognostic indicator. However, what we also know is that the presence of HER2 is predictive and that those patients who have HER2-positive breast tumors really benefit from getting HER2-targeted therapies. And ultimately, having these HER2-targeted agents have completely changed the landscape of how we treat this disease. So these are various studies that demonstrated an improvement of giving trastuzumab in terms of improving disease-free survival and overall survival in patients with HER2-positive disease. So there's the HERA trial, which ultimately showed that a year of trastuzumab was beneficial. There was also the NSVP and CCTG studies, which demonstrated this improvement of disease-free survival and overall survival. And then also BCIRG-006, which was an interesting study that looked at an anthracycline-containing regimen, but also looked at giving TCH and demonstrated that those patients who received Herceptin did better. So these are data from B47, which looked at invasive disease-free survival in those who received chemo versus chemo plus trastuzumab. We know one of the things that has really continue to change over the years is the definition of being HER2 positive. We're continuously looking at how to best define these patients. So in the most recent ASCO-CAP guidelines, one of the questions is, what's the most appropriate definition of being HER2 positive? If somebody has a HER2 positive disease, do we need to, that's positive on the surgical specimen? What about also testing on the core? And there were other comments that looked at things like alternative probes and addressing some other common issues. So long story short, the definition of being amplified is having a HER2 to CEP17 ratio of greater than or equal to 2. Especially if that HER2 copy number is greater than or equal to 4 signals per cell. But then there's this group of patients who have these ratios, but then have a HER2 copy number that's less than 4.0 signals per cell, or may have greater than 6 signals per cell, or is somewhere between 4 to 6. And these are patients that it would make sense to do additional workup, including even, for instance, if you looked at this just in a surgical specimen, looking at this in a core, or vice versa. So let's talk about the data in the neoadjuvant adjuvant setting. So originally, the indications for giving neoadjuvant therapy was to improve operability, and then also improve the likelihood of having breast conservation therapy as opposed to doing a mastectomy. Also, we saw that the nodal status changed, and along with that, our surgical colleagues were able to have less morbidity associated with doing more aggressive axillary dissections when they have more disease that's there, and potentially improving the rates of things like comorbidity. But increasingly, we've learned that biology is king, and that those patients who have a pathologic complete response do better than those who have residual disease. And this has really been borne out, in particular for patients who have HER2-positive breast tumors, as well as those with triple-negative breast tumors. Although it's also important to mind that it's not perfect. Some patients who have PCR still relapse, and then many patients who have residual disease don't relapse. So those patients who have some residual disease doesn't necessarily need to throw us into despair. So who should be considered for preoperative systemic therapy for early stage breast cancer? High tumor volume to breast ratio, those patients who have lymph node positive disease. I would argue all patients with HER2 positive disease or triple negative breast cancer, maybe those patients who have smaller tumors, for instance, like, T1A, T1B, those patients can clearly go to surgery. But we always, for those patients who have T1C and 0, these are conversations that we have with our surgical colleagues about what to do, because there's some data about de-escalating just in the adjuvant setting. But then for those patients who have high-grade hormone receptor positive, HER2 negative, proliferative tumors, sometimes we give them neoadjuvant therapy as well. But again, those patients who have HER2 positive disease, just to remain on topic, who have tumors that are at least 2 centimeters or greater, or have node positive disease, these are patients who I think across the board should receive neoadjuvant chemotherapy, and there's approval for giving trastuzumab and pertuzumab to those patients. So these are the pivotal studies. There's the Neosphere trial, but then also the Trifina study. In Neosphere, you can see there are various arms that were given. These were all taxane-based in the neoadjuvant setting, and then they could have received an anthracycline in the adjuvant setting. There were patients who received some who received just Herceptin, some who received Herceptin plus Perjeta. There was one interesting arm of getting Herceptin and Perjeta followed by surgery, and then they could have gotten chemotherapy in the adjuvant setting. And then there's the Trifina study, which looked at, the primary endpoint of this was a cardiac safety endpoint, and looked at giving TCHP, and then also compared to TCH, and then also an anthracycline-containing regimen. So in the Neosphere trial, you can see that the number of patients who are node negative at surgery, and the rate of those patients having a PCR, and there were also patients who were node positive who at the time of surgery had a pathologic complete response. And the other thing that's been consistent just kind of across the board is that those patients with hormone receptor negative tumors that are HER2 positive seem to have a higher PCR rate compared to those that are hormone receptor positive and HER2 positive. And in the hormone receptor negative HER2 positive group, that rate of having a PCR is about 2/3. So in the Trifina study, again, you can see that, so first of all, there were no new or unexpected cardiac adverse events. And if you look at those patients who received TCHP, meaning they didn't get an anthracycline, these patients seem to do, in terms of PCR, just as well. And I think these data led me to really focus on giving non-anthracyclines, not giving anthracyclines to my patients with HER2 positive disease, just because we can see such robust responses with Herceptin and Perjeta. So if you look at those patients, across various studies, who, you look at those who have PCR versus those that don't, and you look at the disease-free survival, clearly those patients who have PCR tend to do better compared to those that do not. But again, this isn't perfect. And if you have a PCR, doesn't mean that you're definitely not going to get a recurrence. And if you don't have a PCR, you can still be cured. So again, when we think about this debate of anthracyclines or non-anthracyclines, in the HER2 targeted era, do we really still need to give anthracyclines? Because anthracyclines can still cause cardiac toxicity and leukemia. We have data now from BCRG-006, which is a study that I mentioned in the adjuvant setting where patients received anthracycline or non-anthracycline regimens with or without Herceptin. And you can see that patients still with an anthracycline can develop ejection fraction issues and cardiac, long-term cardiac issues. Of course, we know that some of the cardiac risk factors associated with the cardiomyopathy include things like age and patients who are on antihypertensives, especially uncontrolled hypertension. So this is the schema for BCRG-006, where patients received ACT versus AC followed by TH or TCH. And you can see when you compare those who got ACTH versus TCH, that the rates of distant mets were quite similar numerically, but again, there was a higher rate of cardiac heart failure in those who received an anthracycline. So one of the questions has been, can we shorten the duration of trastuzumab? And there were various studies that looked to answer this question. And we've seen really some mixed data. So in particular, I just want to point out the FAIR study and then also the Persephone study, which were non-inferiority studies, which one study showed us that doing 6 months was not inferior to 12 months, and then the other showed us the exact opposite. So at the end of the day, what I'm just going to summarize and say about shortening the duration of trastuzumab is that 1 year of trastuzumab remains the standard. But if you have a patient who for some reason is not able to continue for a year, or if you live in a country where it's just an egregiously expensive medicine or may not be available, if you have to give a shorter duration, it's better than nothing. So for instance, if I have a patient who comes in and, she has, significant cardiac toxicity and we're not able to resume for some reason, even though generally we think of heart failure from trastuzumab being a reversible effect. But if for some reason we see that, I would feel comfortable stopping, or for another reason, if she's not able to continue a year. It's not the end of the world, even though we really want to continue for a year. So I mentioned earlier that we have data about de-escalating therapy. So I want to just mention the APT study. So this was a study of giving in the adjuvant setting Herceptin plus paclitaxel in those patients who have tumors that were less than 3 centimeters and were node negative. And patients received 80 milligrams per meter squared plus trastuzumab, followed by a year of trastuzumab. And you can see the breakout here that the vast majority of patients had either T1B or T1C disease. There's very few patients who had T2 disease. And the 2/3 of patients had hormone receptor positive breast cancer. And you can see patients did extremely well. So there were about 400 patients who were enrolled. And you can see that regardless of hormone receptor status, which is the curve on the right, patients still have an excellent 7-year disease-free survival. So this really showed us that patients, with de-escalation of therapy can still do well. And I just want to highlight that there are ongoing studies that are looking at this de-escalation and escalation question, for instance, the COMPASS studies. So I just want to point out that, for instance, in this study, if patients get neoadjuvant therapy and they have residual disease, they are randomized to receive TDM1, which is really the standard for those patients now, versus TDM1 plus tucatinib. Tucatinib, we'll talk about in just a bit, which is approved in the metastatic setting. And one of the questions with tucatinib is whether this will help, if it's given in combination with TDM1, improve the rates of recurrence. In particular, we'll see if it helps improve the rates of brain metastasis. So in terms of adjuvant therapy, recent FDA approvals include neratinib, pertuzumab, and TDM1. Neratinib was approved in 2017 as extended adjuvant treatment for patients with HER2-positive disease following adjuvant trastuzumab-based therapy. Trastuzumab and pertuzumab, this received FDA approval in 2017. We already mentioned this is for neoadjuvant therapy for those patients who have new-positive disease or it's greater than 2 centimeters, but it was also approved in the adjuvant setting based upon a different randomized study where for those patients, in particular those patients who have node-positive disease, it demonstrated a benefit. And then in the operable setting, I already kind of alluded to the Catnip trial, which was a study for patients who have received neoadjuvant chemo plus HER2-targeted therapy, have residual disease. Then there was a benefit for giving TDM1 versus giving Herceptin. So how do we apply these data? All of them have shown an improvement in disease-free survival, but they can all be associated with an increased risk in toxicity. So this begs the question, how much benefit can be expected for an individual patient by adding pertuzumab to standard trastuzumab-based therapy by utilizing TDM1 for patients with no residual disease or by extending adjuvant therapy with 1 year of neratinib? So let's talk about neratinib first. So this is the extended study. This was a 5-year update. So this study underwent various changes in its design over the years, but ultimately this was a study for patients with HER2-positive stage 1 through 3 disease. Patients could have no positive disease or negative disease or residual disease after neoadjuvant therapy. And patients were randomized to a year of neratinib versus placebo. And one of the limitations of the study is that these patients didn't receive prior pertuzumab. So the primary analysis at 2 years showed this benefit of about a 2% benefit of neratinib versus placebo. Again, the control arm did well, right? So this is the 5-year invasive disease-free survival analysis, and you can see that 87% of patients in the placebo arm did not have a recurrence compared to the 90%. But if you look at this time period, if you look at this 5-year time period, you can see this continued benefit of about 2 years or so. So the benefit, the 5-year analysis really seemed to be restricted to those patients who had hormone receptor positive, HER2-positive disease, not so much that was hormone receptor negative. But then when you also look at some other subgrouping, there seemed to be greater benefit if you were hormone receptor positive and less than a year from the last dose of trastuzumab without PCR after neoadjuvant treatment. And the delta was a little bit smaller for those patients who are hormone receptor positive and less than 1 year from last dose of trastuzumab. So really it's these patients who seem to have the greatest delta, hormone receptor positive, HER2 positive, finished Herceptin relatively recently within the last year and had some residual disease. So one of the issues that we've had with neratinib has been just controlling the main toxicity being diarrhea. But then there was the controlled study, which was an open label study, which looked at giving various preventative agents such as loperamide or budesonide or cholesterol. And ultimately, these approaches work. So if you look at the rate of having discontinuation, for instance, it's higher just with giving Imodium compared to, for instance, giving cholesterol plus Imodium or cholesterol with Imodium PRN. So this really does help in terms of decreasing the main toxicity associated with neratinib. And then you can see, again, just that things seem to be better controlled. This is if you don't do prophylaxis, and then you can see if you just give Imodium or if you give Imodium plus budesonide or Imodium plus cholesterol. This looks at just the time out, so 1 month, 2 months, 3 months, etc. But you can just see over time, it's better to just have these agents given because it decreases the likelihood of that toxicity. So moving along, I wanted to talk about the Affinity Study. So Affinity was the study that got the approval of pertuzumab in the adjuvant setting. So this study included patients with HER2-positive breast cancer, any node positivity with any tumor size, or if they were node negative, they had to have a tumor that was at least 1 centimeter, but it did include some smaller tumors that were node negative, but for instance, were hormone receptor negative or had some other higher risk features. And the primary endpoint was invasive disease-free survival, and the study design was giving pertuzumab plus trastuzumab plus chemo versus doing trastuzumab plus chemo alone. There was a second interim analysis that was reported at San Antonio, and this was a median follow-up of about 74 months. And you can see that with this, if you look at the intention to treat population, it was like a near 3% advantage at that time point, and that remains statistically significant. The node positive population continues to be the one who seems to be deriving the greatest benefit. So you can see that this absolute benefit is nearing about a little more than 4%. Then in the node negatives, they don't really seem to be benefiting, but it's the node positives who have a high hazard ratio of about 0.7. But now one of the things that was seen that wasn't previously seen at the shorter analysis is that we're starting to see some benefit in terms of in the hormone receptor positive, HER2 positive setting. We're now at that time point of about 6 years, there's a 2.5% improvement in PCR. And in the, oh, sorry, that was a hormone receptor negative cohort where you see that. In the hormone receptor positive cohort, there's also, this like around 3% benefit at that time point. And the hazard ratios are kind of nearing each other. So again, 2.5% in the intention to treat population for the hormone receptor negative, and for the HER2 positive was 3%. So in terms of the toxicities, we know these adverse events that can be associated with pertuzumab. I just want to highlight in particular things like diarrhea and then also rash. But it does not seem to increase the risk of cardiac toxicity. And then lastly, I just want to talk about the Catherine study. So this was for sure a practice-changing study in which patients who had clinical T1 through T4 and 0 through N3 disease. So this did not include patients with T1A, T1B, or N0 disease who received neoadjuvant therapy. They must have received a minimum of 9 weeks of taxane. They were allowed to have received an anthracycline, and they must have received HER2, even though things like pertuzumab or a second HER2 target agent was allowed. And patients were randomized to TDM1 versus Herceptin if they had residual disease. And it's worth noting that these were balanced. About 3/4 of patients had operable disease, about 3/4 had hormone receptor positive disease, but 80% received Herceptin alone. About 20% had received pertuzumab, and about half were node positive. And this Kaplan-Meier curve tells the whole story, where if you look at the 3-year invasive disease-free survival, we're seeing this impressive improvement in outcome. The other thing just to mention, if you look at the subgroups, the hazard ratio is the same regardless of hormone receptor status, about the same regardless of whether they received Perjeta or not, even though this number was smaller, regardless if they had pathologically node positive or node negative disease, and then regardless on the size of the residual tumor. So this across the board did benefit patients to switch to TDM1. So the toxicities we can see from TDM1, just to highlight those: thrombocytopenia, an increase in LFT abnormalities, and sensory neuropathy. And about 80% of patients in the study were able to complete 14 cycles of that. It was about the same as what we saw with trastuzumab. So in terms of the first invasive disease-free survival effects, so this is TDM1 and this is Herceptin. You can see that this significantly improved the rates of distant recurrence, not so much CNS, and that's something that we'll continue to see over time, and also decrease the likelihood of having local regional recurrence. So again, we still have this remains an unmet need to improve the rate of CNS metastasis. And I mentioned this ongoing study that's going on within the cooperative groups that's looking at adding into Catnip to TDM1, with the question being whether or not we can, in particular, decrease the rates of CNS metastasis in this group. So to put all of this into context, we talked about Extenet, we talked about Affinity, and we talked about Catherine, and we talked about the entry criteria. So in terms of node negative disease, Catherine had the highest rate. About 3/4 of all of these patients received prior anthracyclines. You can see the rate of the hormone receptor positivity, and I showed you the results of the 5-year, 3-year outcomes and that associated hazard ratios. So to just kind of put this all into context, if a patient has a clinical T1A, T1B disease, it's totally appropriate to just give half of the patients go to surgery and then give something like Taxol Herceptin based upon the APT study. If patients have T1C N0 disease, there are various things that can help define this. What's the age? What's the size of the tumor? This is hormone receptor negative. But there's a difference between somebody who's 80 years old and has a 1 centimeter hormone receptor positive, HER2 positive breast cancer compared to somebody who's 40 years old and has a 1.9 centimeter node negative, hormone receptor negative, HER2 positive breast cancer. So in terms of those patients who have clinical node positive disease or tumors that are greater than 2 centimeters, they would get neoadjuvant therapy with pertuzumab. I would argue, based upon the data from BCRG that I mentioned, but also most recently based upon the TRAIN2 study, which was a study that compared giving anthracycline versus non-anthracycline regimens in the HER2 positive setting. These data were just recently updated at ASCO. I would argue that there really is not a role for an anthracycline in the operable setting. The outcome is the same. In my practice, I give TCHP, and if they have residual disease, TDM1, and then potentially neratinib if they're hormone receptor positive. But again, none of those patients received prior TDM1 or pertuzumab in the extant study. If patients do have a PCR, then what do we do? So oftentimes we continue Herceptin for a year. We do that for all patients. But then, for those patients who have high-risk features, such as those who are hormone receptor negative, I would argue that we give them a full year of pertuzumab. If patients have a PCR, one of, I think, the outstanding questions is, do we need to continue a full year of Perjeta, particularly if they have low-risk features or are hormone receptor positive? But that's, kind of up for discussion. Again, this question of giving neratinib for those patients with hormone receptor positive disease, but all the caveats that I've already mentioned. So that was a whirlwind through the early stage breast cancer setting. I just now want to focus on metastatic disease and how we incorporate HER2 targeted agents. So I wanted to spend just a little bit of time talking about the DESTINY study. So this was a study that led to the approval of DSA-201 or trastuzumab deruxtecan. There were various arms in this, but ultimately the continuation dose that was being evaluated was 5.4 milligrams per kilogram. And you can see this population in terms of their median age, where they came from, the ECOG performance status, and you can see the prior agents. Everybody previously had Herceptin. Again, we're talking about patients with metastatic disease. All of them had prior TDM1, but 3/4 of them had prior pertuzumab, and patients had other HER2 agents. And then here's the waterfall plot curve. And, it's very infrequent in breast cancer to see waterfall plot curves like this. So this is what led to the approval of trastuzumab deruxtecan. We can see this incredibly impressive waterfall plot curve in patients with pretreated HER2 disease. This slide speaks for itself. And you can see the progression-free survival and the overall survival, but again, this is a single-arm study. Side effects. So you can see things like gastrointestinal side effects, but the main side effect to be aware of with this drug is interstitial lung disease or pneumonitis, okay? About 2% of patients in the study developed this and died. So this is something to really, really, really be mindful of. So if you have a patient who has asymptomatic ILD, you can consider giving steroids, and then you withhold the trastuzumab deruxtecan until it recovers. But if it's grade 2 or higher, you give steroids, and then you stop trastuzumab deruxtecan, no mas. And unfortunately, we don't have any great predictors for who develops this toxicity, as a prior radiation. We really don't know. But this, for sure, everybody who gets this drug needs to be aware of. So then I mentioned that we would be discussing NALA. So NALA was the study of giving neratinib plus capecitabine versus lapatinib plus capecitabine in patients with HER2 positive disease. I just want to point out that the dose of capecitabine in the lapatinib arm was higher than what it was in the neratinib arm. And the co-primary endpoints was overall survival and progression-free survival. So you can see matched. About 60% of patients had hormone receptor positive disease, about 40% had de novo metastatic disease. Very few patients had prior pertuzumab and trastuzumab, but about a third of patients actually had trastuzumab and pertuzumab and T-DM1. It was actually only about 30 to 40% who only had trastuzumab, just to clarify that. So there was this 2-month improvement in progression-free survival, as well as this 1.7-month improvement, which was just a numerical trend with neratinib. But one of the things that's just worth noting is that neratinib does seem to be better in terms of the time to an intervention for CNS metastasis of neratinib versus lapatinib. Side effects, just to continue the theme, things like diarrhea, hand-foot syndrome. We talked already about the preventative medicines that you can give for neratinib, but also things like nausea and vomiting and anorexia. So then I also just want to mention Catnip, which is a HER2 selective TKI. This drug was just recently approved. This is, as I said, more selective in that it has higher selectivity for HER2 and not really also having off target with EGFR. There were some exciting data of giving Catnip and T-DM1 in a phase 1b that's been reported. And this was the study that was discussed at San Antonio in 2019 and published in the New England Journal of Medicine and led to the approval of Catnip. So this was a study in which patients received Catnip plus trastuzumab plus capecitabine versus trastuzumab plus capecitabine alone. And one of the notable things about the study is that patients were allowed to have brain metastasis, and all these patients had prior trastuzumab, pertuzumab, and T-DM1. So this really reflects our current population. So about 60% of patients had hormone receptor positive disease. About a third of them were stage 4 at diagnosis. And you can see that about 50% of patients had a presence or history of brain metastasis. So here you go. Here's the progression-free survival advantage. And you can see that there was this numeric improvement of about 2 months. But importantly, I think, when you look at this landmark analysis at 1 year of progression-free survival, about a third of patients were still progression-free if they got to Catnip versus about 12% if they received placebo. And really, across all the arms, across all of the subgroups, there's benefit, regardless of hormone receptor status or region of the world, and also whether they had baseline brain metastasis or not. It's all favoring giving Catnip. And then we also saw this overall survival data. This is exciting. And I just want to highlight this 2-year overall survival difference of 45% in those who received Catnip versus 27% who received placebo. And this is meaningful. So this is an exciting new drug in our armamentarium. It was pretty much across the board beneficial. There seemed to be this greater benefit in those who were negative for the hormone receptor status in terms of overall survival. In the hormone receptor positive group that did cross 1. And then if you look at brain metastasis, so again, this is a drug that is known to cross the CNS. When you look at progression-free survival with those with brain mets, at a year, 25% of those who received Catnip remained progression-free. So side effects include things like diarrhea or PPE, nausea, but in general, when we think about TKIs, this is a well-tolerated drug. So I did spend some time really focusing on brain metastasis. So then there were some more recent data about those who had stable brain mets or active brain mets. Either they were untreated or treated in progressing. And you can see, again, just those patients with brain metastasis, how much better they do when they get to Catnip in combination with Tras plus Cape compared to Tras plus Cape alone, with Cape being a drug that we think of giving some good CNS penetration. And the median CNS PFS was more than double. And by 1 year, I already, just to stress the point, 40% of patients remain in the CNS progression-free. So when you look at the subgroups of brain mets like stable versus active, across the board, Catnip offered improvement, including an overall survival advantage in those patients with active brain mets. To summarize all of those things that I just mentioned, we talked about the DESTINY study, which led to the approval of trastuzumab deruxtecan. We talked about HER2 climb, and we talked about NALA. You can see just how patients did overall and what their survival looked like and the response rate. Trastuzumab deruxtecan having this impressive response rate of nearly 60%. And then, we talked about the fact that neratinib really seems to have, Catnip really seems to have some impact in terms of CNS mets, as does neratinib as well. There are some data that have been reported about trastuzumab deruxtecan in a smaller cohort, which does suggest that maybe some of the payload does come in and treat CNS metastasis, and there will be more to come on this. So this is a nice illustration of the timeline, right? So we saw approval in 2019 of neratinib based upon the NALA data in the metastatic setting, and then we've had trastuzumab deruxtecan, we saw the initial phase 3 data here, and this did have some NCCN approval, and then the FDA approval for neratinib and capecitabine was earlier this year. And then I mentioned the results of HER2 climb, which ultimately very quickly led to the approval of Catnip in the metastatic setting. So where are we going? So there are a number of ongoing studies just that I wanted to make sure that you are alerted about. So one of the questions really has been about what's the role for immunotherapy. So there's an ongoing frontline trial of giving paclitaxel plus trastuzumab plus Perjeta, plus or minus giving this PD-L1 inhibitor atezolizumab. So that is ongoing. There's HER2 climb 2, which is a study of giving for those patients who've had prior treatment of trastuzumab and taxane and are allowed to have prior pertuzumab, but it's not required, where patients are randomized to Catnip plus TDM1 versus TDM1 alone. And then there is DESTINY 2, which is a study of an open label study in which patients had received prior HER2 therapy, including TDM1, where patients are randomized to trastuzumab deruxtecan or investigator choice of trastuzumab cape or lapatinib cape. And then there's the second line study, which is a randomized phase 3 trial of patients who received prior trastuzumab and taxane. Again, second line of trastuzumab deruxtecan versus TDM1. And then there's also an ongoing study, DESTINY 4, for patients with HER2 low disease, because there's some data from a phase 1 study which showed that the waterfall plot was just as impressive for those who had HER2 low disease, defined as 1 or 2 plus and non-amplified, compared to those, and that curve looked similar to what was seen in the HER2 positive arm. And in this study, they're looking at giving trastuzumab deruxtecan versus physician choice chemotherapy. So that was really a quick and dirty review of HER2 positive breast cancer. Again, I just want to reiterate the point that we've really made some significant advances in HER2 positive disease. In the early stage setting, we have the approval of pertuzumab. We also have TDM1 in the residual disease setting. Also, neratinib is an option for those patients with extended endocrine therapy. There are data about de-escalating and withholding an anthracycline in that setting. And then we've had some recent approvals, beyond the game changers of pertuzumab and TDM1 in the metastatic setting. We also now have Catnip, we have DSA201, we have neratinib. We're waiting to see about whether there's a role for immunotherapy. And then there are other exciting agents that are being explored, other TKIs such as paratinib, and then there are other antibody drug conjugates and HER2 agents that are HER2 agents in combination with immunotherapeutics that are being explored. Again, my email is kk2693@cumc.columbia.edu. If you have any questions, you are more than welcome to reach out to me. Thank you for your time.